So this is a typical sign whenever patient is having pain in the hip area or the ankle joint. So what patient's tendency is, patient tries to avoid more weight bearing on the affected limb, and that is the reason that we will notice that stance time on that particular affected side will be less, and that is the reason that patient will walk like that patient is limping. So basically avoiding weight bearing on that particular side and walking is called as limping gait or antalgic.
The last gait that I'm going to demonstrate is the ataxic gait. In the ataxic gait, the patient has difficulty narrowing the station and maintaining balance. So typically they'll have a wide stance, is trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior-posterior tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Now, of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, and I then try to walk tandem, then I'm going to have difficulty walking. This gait is the gait that is a hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture in which he'll be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this, and as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again having difficulty starting in the marche petit pas. As opposed to the hypokinetic gait, we now have the hyperkinetic gait, which we see what we call a choreiform gait or chorea. With this gait, there are not only abnormalities in the gait itself, but associated movements. There can be orofacial dyskinesias, in which the patient will be having movements of one side or the other side of the face, kind of a grimacing type of a fashion. There can be movements in the upper extremities, and there are fragments of semi-purposeful type of movements or writhing type of movements. And then the legs will also start to go. And so the patient attempts to walk, get the superimposition of the movements, but the patient doesn't actually fall because the balance is not affected. Just you have these involuntary movements that are now being superimposed on the gait. The gait that I'm going to demonstrate now is the hemiparetic gait. This gait, if we were to demonstrate it, we need to be able to show the extension of the leg and internal rotation. So the leg is too long. We get circumduction with the paretic side, but very importantly as well is that the upper extremity is very much involved, and so there's adduction of the shoulder, flexion of the elbow, pronation of the wrist, the thumb is tucked under, and a cortical fist. So this is the position of the hemiparetic gait, with the other side being normal, having normal associative movements. You can actually hear the pattern of the gait as well as we have circumduction for the product side. Again, watching upper extremity posture, the decordicate posture, lower extremity is actually circumducted coming around. The next gait is the spastic diplegic gait. In this particular gait, both lower extremities are affected, and the lower extremities are affected more than the upper extremities. So the posture, the position in this particular gait is there's flexion at the hips, flexion at the knees, and the feet or the ankles are extended and internally rotated, and there's also tight adductors, so there's adduction at the knees. So it is a swinging gait with both sides, both lower extremities. You can hear a different pattern than the paretic gait. But this is not all. The upper extremities are also involved. Again, not as much as the hemiparetic gait, but for the upper extremities, the extremity is carried in a low guard or a mid-guard position, and you don't have the normal associated movements in the upper extremity. So this would be the type of posture and type of position that one would see for the spastic diplegic.
This is a typical gait we will notice whenever patient is having adductor muscle tightness. Patient will have tendency of walking in scissoring pattern because adductor muscles are very tight, or else there is weakness of the abductor muscles which doesn't allow leg to move in the abduction, and so that patient has more tendency towards walking with the adductor pattern.
Next is the gait of the sensory ataxia or dorsal column lesion. When the person starts walking normally, lights are there, everything is fine, the visual compensation is present. But once there is darkness or darkness prevails, the person doesn't know where is the ground. The person will stamp her feet. Stamp. This is stamping gait. Next is a gait of frontal lobe disease or normal crescent hydrocephalus, which is known as gait apraxia. As you know, apraxia is defined as forgetfulness of learned memory, or in other words, inability to carry out a command, even if the person is having normal motor, sensory, cerebellar, no cerebellar signs, no other ataxias, and normal psychiatric function. There is no problem in psychiatric disease. So this kind of person, they are not able to carry out the command. When I talk of gait apraxia, so he has forgotten how to walk. So for example, normal crescent hydrocephalus.
चलिए आगे चलिए और चलिए आगे चलिए.
Now you will ask me what is the difference between the freezing episode of Parkinson's disease and this gait apraxia, because here also the patient is glued to the ground. He doesn't know, but the basic difference will be if you ask the patient of a gait apraxia to use the lower limbs when he is not walking, he will fantastically do the lower limb working of the lower limb. Say for example, show me how to ride a bicycle lying down. A gait apraxia patient will utilize the lower limbs like this. He knows. But when it comes to again walking, there is the same problem. He is not able to initiate a walk. This is gait apraxia. A Parkinson disease patient will be having glute freezing episode, but if you ask the Parkinson's patient to bicycle, he won't be able to do it because it is already rigid. He won't be able to do it. This is the difference between gait apraxia and Parkinson's gait.
The next gait is going to be that of a neuropathic gait in which the distal lower extremity is affected. For this particular gait, the person has the inability to dorsiflex the foot, and so the foot is actually a foot drop, and the person must step high in order to clear the foot. So if I don't step high enough, I'm going to drag the toe of the shoe, and so what happens is the person steps high to be able to clear the foot. As the foot drags, or as the foot drop position.
we are trying to show is a gait of lower motor neuron disease, say for example a poliomyelitis. The complete one of the lower limbs is paralyzed and it is a lower motor neuron limb. So say for example how the patient manages his limb because of complete hypotonia and complete paralysis. This is how they manage their lower limbs, and say for example this patient will walk. They will use support obviously. Usually these patients they use crutches or they have sliding seats made for them. They will drag their limb like this. They will use both their hands and they will try to drag the limb. Gait that will occur in a case of foot drop. Say for example due to common peroneal nerve palsy or L5 radiculopathy, so there is a foot drop on the left side. So this patient when he starts to walk, he will injure his foot. So what he will do, he will, to avoid injury, he will take a higher step, high steppage gait. He will take high steps. So this is a high steppage gait of foot drop. So next is the myopathy gait. There is, say for example, proximal girdle myopathy, both hips are weak. So this person will be having a broad-based gait with an exaggerated Trendelenburg manifestation. That is, the trunk compensates to lift the hip. The trunk will compensate to lift the hip.
Perfect. Yes. So this gait mostly you will see in polio patients where they have quadricep muscle weakness, which will not allow knee to go for complete extension, especially when person is performing heel strike. So that is the reason when person tries to walk during the heel strike, they will try to push the knee back in extension position, and that is why we call it as hand to knee gait, especially seen in the quadriceps weakness patients. So this kind of gait we will notice whenever patient is having gluteus maximus muscle weakness. This is also called as pregnant lady gait if patient is having gluteus maximus muscle weakness on the both the sides. So in this what happens is when patient is trying to perform heel off or toe off, patient has to perform hip extension, and if gluteus maximus muscle is weak, patient is unable to do so, and that is why patient tries to keep a hand over the gluteus maximus muscle and tries to lean backward so that easily hip extension can be occurred and patient can walk easily. Now the next pathological gait is also called as gluteus medius gait, in which opposite side of the pelvis is dropped because of the weakness of the gluteus medius muscle. So here, for example, my right side gluteus medius muscle is weak, then while walking, if I am lifting off the left foot, it will drop down like this. Again, when person is walking, it will drop down like this. Again, it will drop down like this, because the gluteus medius muscles work is basically to hold the pelvis upward whenever it is not in supported position.
The left hip, which is the stiff hip, during the swing phase, he rotates the entire body, pivoting on the right hip to move forward. That is the characteristic of a stiff hip gait.